Go.
Hi, everybody. Thank you for joining. We'll start in about 4 minutes, so exactly at 7:05 Central. We're just giving everybody some time to tune in.
Awesome. See you then. All right, hey everybody. Welcome back. Thank you so much for joining us. We really appreciate it. We are happy to have Jessica today. I know a lot of you guys are really excited that she's a psychiatric PA, so that's something we have never had before, and we're really interested to see how this goes. As usual, guys, the chat, I will be keeping an eye on it, and if you have any questions at all the whole way through, just let us know. I will relay them back to Jessica as best we can. We like to, if possible, kind of keep on topic with the question. So if you have a general question, more than likely I'll ask it at the end during the Q&A. But if you have something to ask about the case study that she's currently doing or the topic she's currently talking about, we'll try and do that a little bit quicker. The only other thing is the quiz, which Ollie will tell you about.
So as usual, we'll send out the link in the chat at the end, and as long as you get 4 out of 5 correct, we'll email that certificate to you within about a week.
All right, awesome, guys. Good to see you. Without further ado, Jessica, if you're ready, it's all you.
All right, I think I'm...
Oh, and just to, kind of give you an idea, we have about 175 people here, and we only expect that more will join. So these people must really like you, I guess.
Very nice.
All right, all you. Thank you. Let us know.
Thanks. Okay, so my name is Jessica Lepe. I'm a physician assistant. I work in psychiatry. Yeah, not a lot of PAs that work in psychiatry. I think in total there's about under 2,000 PAs working in psychiatry right now. I think it's under it's like 1.5% of all PAs that practice in psychiatry. So definitely something that could use a lot more PAs in. But just going to go a little into about my background and becoming a PA. And then we'll get into a little bit about my job and my position, and then go over a couple of case studies and things that I might see on the day-to-day as a PA in psychiatry. All right, so just starting off with some disclosures. All opinions and everything that I talk about in this presentation are completely my own and in no way represent any of the organizations or my employer that I mentioned in the presentation. And then all of the case presentations and patients that I referred to, whether they are slightly based on real life patients, any sort of identifying information has been altered so that it's not revealing any private patient information. So a little bit about me. I grew up in Cicero, Illinois, a suburb right outside of the Chicagoland area. Born and raised there, just went to public schools. In high school, didn't really do anything too exciting, nothing very much that stood out. I knew that I wanted to get into something medical when I went to college, but wasn't sure exactly. As a lot of people kind of think in the beginning, I was kind of leaning more towards medical school. PA school was not really anything that I had really ever even heard of. I didn't really know much about physician assistants, so that was really the only route that I thought I really had to go. So I went to the University of Illinois at Chicago, and I got my degree in biology. During undergrad, my grades were pretty okay, nothing super special. I got an overall 3.5 GPA, and my science GPA was 3.2. Didn't apply to medical school because realized that just wasn't something that was for me. And it was actually halfway through college that I found out about the physician assistant career from somebody else who was actually applying to PA school. And that kind of threw me into really looking into it and realizing that that was exactly something that would fit with my life and what I wanted in my future. So that set me on that path and trying to make sure that I got all of my prereqs and everything that would be needed for PA school. And I'll kind of talk about some of my CASPA stats and things like that on the next slide. But for PA school, I did go to Dominican University in River Forest, Illinois, again, suburbs in Chicago. And I got my master's in medical science in physician assistant studies. I was actually part of the first class that Dominican had in physician assistant studies. So we were the first students in their program. Everything was brand new. I know that that is something that a lot of people are sometimes concerned about or confused about when it comes to schools that are starting new programs, and whether that's something that is going to be equivalent to something that's a more established program. So I'll answer any questions about that too a little later. But let's go into some of my activities and background to what I did before PA school. So really my application wasn't super astounding or anything that was really crazy, really. I honestly, when applying to PA school, I didn't think I was ready to apply, and I almost didn't apply, but I figured it would be a good practice just to apply before I felt like my application was really ready. So I applied right after graduating from undergrad. I had about 500 hours of patient care experience as a provider where I was actually taking care hands-on with patients. So I got my certificate as an EMT in a course at my college while I was in my senior year. And then I started working part-time on a private ambulance company. We didn't really ever have any emergencies. It was mostly patient transportation. We, checked vitals, checked medical history, just made sure the patients were safe on their ride to wherever they were going, whether it be a nursing home or another hospital. But after a couple months of that, with my EMT certificate, I got a job as a patient care technician at a hospital on a general med surg floor. So basically similar to a CNA is what I was doing, getting vitals on patients, making sure that they had, clean towels, their bed sheets were changed if needed, taking care of whatever they needed, whether it was assistance with food or hygiene. So that was a lot better for me in what I was looking for, because I loved being in the hospital and actually getting to really provide care for patients, as opposed to while I was an EMT. I didn't really get to be as hands-on because most patients really didn't need anything, but that helped me get to there. In terms of my healthcare experience in general, besides what I did getting paid and for my experience hours, I had about 150 hours of general hospital volunteering. So I volunteered at a big hospital in Chicago for a couple hours a week for like 2 or 3 years. And we weren't really ever really interacting with patients. It was usually stuff like going on deliveries, seeing if a certain department needed help with paperwork or whatever it was. So that was just nice, kind of being in the hospital environment, but didn't really expose me too much to what the medical staff was doing, what PAs were doing, but it was still nice to get that experience. I also spent a week during undergrad in doing an alternative spring break. So during it was actually winter break for a week. We went on a trip to New York, me and I think 10 other people, and we spent a week volunteering at this place called Sunshine's Children's Home and Rehab Center. Basically, this was a home where maybe 20 kids, so people under the age of 18, who had special needs that required 24-hour care. So they lived in this facility full time, and they were provided with all types of care, different types of therapy, occupational therapy, physical therapy. They had school that they all went to there for all the different ages, and they had evening fun activities for all the kids. So we kind of helped with a lot of different aspects in that, planning fun activities for them, observing the different therapies that they went through. So that was definitely an interesting thing to be able to be a part of and spend some time doing. Another thing that I think really was something that more so maybe set me apart or did kind of make me stand out in a way is my personal life experience that I had as a patient that actually made me want to get into the medical field. And I'll go into that a little bit more in the next slide. I'll talk about my personal statement and things like that. So for shadowing, I was just talking before this started about how great of an idea that this is, especially with everything with COVID going on. I'm sure it's really hard to find people to shadow because there's so many rules in a lot of places about how many people can be somewhere. And obviously, we want to reduce COVID from being spread. And even in general, shadowing can be something really hard to do. I know I really struggled when I was looking for PAs to shadow to get to my application minimums that a lot of schools had. And I was living in Chicago, where there's tons of hospitals, tons of medical centers, and just really struggled trying to get in contact with PAs and getting that time to shadow. So I really only shadowed PAs for 2 days. That got me to my minimum 15 hours that one of the applications needed for shadowing. And of course, more, there's always minimums, and it's always better to have much more than that. But I did shadow a PA in gynecological oncology, and she was working in a clinic at a hospital, as well as a PA who worked in orthopedic surgery. And I shadowed him during a day in clinic. And then I also had shadowed a doctor in pediatric oncology. Still had that on my application, sense of saying, I want to go the PA route, but I've spent time with doctors as well, and I know that that is not the route that I want to go. So going into letters of recommendation, I didn't have one from a PA because I had only shadowed PAs for 1 day each, so I didn't really have a good relationship with them. So I had a research supervisor that I did in undergrad. I worked as a research assistant, so worked with him for 2 years. So he provided a letter, as well as the pediatric oncologist that I had shadowed. So that kind of goes into my personal experience as a patient that I will talk about right now. And then also a professor, I don't even remember what professor it was, just someone from college that kind of fulfilled that requirement that you needed a letter from a professor. My GRE was, I think, pretty good, 320 total. And then, so my personal statement, again, going into, I overall don't feel like my application was super stellar or anything that really was above anyone. I had okay grades, I had okay test scores, I had very minimal experience compared to a lot of other people. Really the only schools that I applied to when I did apply to schools were that new program that had a 500-hour minimum of healthcare patient care experience, which is how much I had. And then the other two didn't have minimums, but of course the average patient care hours was like 2,000 hours, but I figured I'd, again, just apply anyways, just to try it out. So my personal experience as a patient, so I was actually diagnosed with cancer when I was in high school. So I went through about 8 months of chemo, had surgery, and that, was a very big part of my life, and really altered the way that I grew up and who I became as a person. And that's what ultimately made me want to get into the medical career. And originally wanting to be a doctor because I really enjoyed what my doctor provided for me in terms of being a medical provider, knowing that nursing is not exactly what I wanted to do. I wanted to be more on the medical perspective side of things. So, and then, as I say, once I found out about the physician assistant career, that was really just everything that fit best for my life. As I'm sure you all know, all the different pros and cons versus, each different medical field career. And that, led me down this path. So I ended up applying to 3 schools. So the one Dominican that I barely fit the requirements for, and then the 2 other schools that didn't really have minimums, but I figured I'd apply to them anyways. Never heard back from the other 2, but actually got an interview at Dominican. Being that it was a new program, they didn't have as many applicants as a lot of the other programs did, which I think in some sense also did help me out too, because there was less applicants, but I think my story really played its part, and it makes people see why you are actually passionate about things, and what sets you apart from everyone else that wants to be in a PA and go to PA school. Everybody of course wants to be a PA to help people, to make people better, but what really is behind that passion, or what makes you unique, and that's really what you got to work to get across in your application, especially in a personal statement. So going into my post-PA school life, how I ended up in psychiatry. So when I started PA school, I was thinking I wanted to do something maybe in a hospital, maybe surgery related. I really wanted to do something that would have more variety. Maybe some days in the clinic, some days in surgery, some days rounding on patients in the hospital. That was what my ideal schedule life looked like. So even after I finished PA school, I still wasn't really sure exactly what it was I wanted to go into. I liked most of my rotations. I enjoyed them. There wasn't one thing in particular that really stuck out to me that I wanted to do. I actually didn't apply to any jobs until I was done with PA school, and really, I think even after I took the CASPA, not the CASPA, the PANS, just because I was so focused on finishing school and studying for my test. So I started applying to jobs in a bunch of different areas, different specialties, different areas in hospital or in the clinic. And I actually ended up working where I did my clinical rotation in psychiatry. So there was a big Spanish-speaking population at this clinic where I was at, and I was one of maybe 2 students who spoke Spanish in my class. And the person who worked at this clinic really needed more providers who spoke Spanish to help with his patients. And I at first wasn't really interested in psychiatry. It was actually probably the thing I was least looking forward to when I started rotations. And it was my first rotation, so I really didn't have anything to compare it to, if it was something I really enjoyed or not. But it was a nice rotation, and I kind of kept in touch, and had actually decided that maybe this wasn't the route I wanted to take. I didn't want to go into a specialty so soon. I felt like I was wasting everything else that I had learned. So I kind of steered away from that. But after really thinking things through and trying to figure out, what kind of life I wanted for myself, what kind of future I saw, somehow ended up back there. So, you look at a lot of different aspects when you're looking at a job. Do you want to work in a clinic? Do you want to work in a hospital? What are the pros and cons that come with those things? So I work in a clinic, so we're only open during clinic hours. So for the most part, my schedule is 9 to 5. I work 2 Saturdays a month in the mornings, and it's really only because I choose to. I don't have to. So that's nice, and I never miss any holidays. I never miss any important things. Where I work at in particular is very flexible. So, if you're starting to work at a hospital for the first time, and you're kind of lower on the totem pole where, you're the newbie. You might be working on Christmas for a couple times, or you might be working other big holidays or overnights, and, maybe not the ideal thing, and maybe that's fine for other people, but for me, that wasn't really something I wanted to do. I didn't want to miss out on things with my family, which was the most important thing for me. So really was the best fit for me, and I loved the place where I worked at, being that it was somewhere that I rotated with. I already knew how the place worked, and it was definitely somewhere I could see myself for a long time. And I've been there for over a year now, and I still really enjoy it. One of the things that has been really great in the past year, obviously COVID-19 has been a major stressor and a big issue in the healthcare system this past year. And as I kind of mentioned, having had some personal health issues in the past, I don't know if I would have kept my job if I had to be working in a hospital, because I have these other underlying health issues where I wouldn't want to put myself at risk like that. So fortunately, our clinic was, and a lot of outpatient psychiatry clinics, fortunately, were able to transition to almost 100% telehealth visits. So I have been actually working from home since March. Unfortunately, I left my charger at the office on the last day that I was there, so I still haven't gotten it back because I haven't returned. And it's, been definitely different, trying to make that connection with patients over video than in person. But it's also been really rewarding to be able to continue care with people when, having to go out and be, in a room where so many patients are. That's a big stressor, and we want to make sure that everybody is as safe as possible. So that's a little bit about what my kind of day-to-day entails. As I said, I usually work Monday through Friday, 9 to 5. Wednesdays I actually work a little later, but I start later, like 10 to 7. And then Saturdays twice a month in the mornings. We do have a lot of different providers at my clinic, and we rotate call responsibility. So again, we're at an outpatient clinic, so we don't really have emergencies. Emergencies would go to the emergency room, but say someone after hours really needs something that's kind of urgent, you might get a phone call after hours, but it's really nothing that requires us to go in anywhere or anything like that. And I personally only see adult patients. I do work sometimes with my collaborating physician who also sees children. So I do see them with him, but I personally don't see children by myself. So I think in terms of general questions, or anything about applications or schools or psychiatry in general, those will be questions we can kind of talk about towards the end. So right now I'm going to go into a little bit about psychiatry specific things and a couple cases. So something that is slightly different from other sort of specialties or areas in medicine. We all do the same sort of history and physical. In psychiatry, it's a little bit different. We don't quite have as much of a physical exam. I don't really perform much physical touch with the patient or anything besides maybe taking vitals, getting blood pressure, pulse, weights. But other than that, we don't really do much else really physically. We'll talk about what we do for the physical exam next, but we really rely heavily on history and the story that the patient has to tell. So obviously, every history and physical, you need to get the patient's identifying information, what is the main problem and what is the history behind it? What are they feeling? When did this begin? Has this ever happened before? And then specifically, we'll go into with the past medical history, what's the patient's past psychiatric history? Have they ever been seen by anyone in psychiatry in the past? Have they ever been hospitalized for any psychiatric reasons? Any past suicide attempts? Are they on, or have they been on any past psychiatric medications? What was helpful, what wasn't helpful? Oftentimes you'll find psychiatric patients have quite an extensive history with different medications. And then again, general past medical issues. You also want to make sure they don't have any general medical conditions that could always interfere with other medications or their mental health. Family history, big thought on whether they have any psychiatric illnesses or substance abuse problems in the family. And if so, have any of those people ever been medicated with anything? While just because a medication worked in a family member doesn't mean it's going to work in a patient. There is some sort of component of genetics and such with some medications. So just something good to know. Social history, very important, especially in psychiatry. Again, going into substance use, alcohol, tobacco, recreational drugs. What kind of job do they have? How long have they been at their job? Where do they live? Who do they live with? What sort of support do they have? Do they have a religion? All these different components are important for any patient, but especially when you're looking at someone in the point of their mental health. Review of systems, we're going to ask the same sort of general physical review of systems as well. Do they have any aches, pains, fevers, things like that? But we're also looking to rule out different psychiatric disorders. Whatever it is they're presenting, does this patient seem to show any signs of mood issues, depression, manic episodes? Have they ever experienced psychosis, so hallucinations, delusions? Or, are they having any thoughts of harming themselves or harming someone else? Always things that we want to inquire about so we can really get a full picture of things. Someone might be feeling very depressed, but it's a whole different story if they've had a manic episode in the past. Then you're going from a major depressive disorder to bipolar disorder. So then we move to the physical part of the exam. So as opposed to, listening to the heart and lungs, feeling the abdomen, range of motion, things like that. What we're really looking for in patients is in terms of physical appearance and things that we're observing, we're doing the mental status exam. This doesn't necessarily have its own specific part in the exam where we, we go through the history and then we start going through the physical and looking at each of these things at once. We're kind of observing all of this throughout the entire evaluation. Again, one of the big differences too is a lot of times in a lot of specialties, you'll see a new patient and you gotta figure out what the problem is and what you're gonna do in 15, 20 minutes sometimes. So I personally, whenever I see a new patient and we're trying to figure out what's going on, we have a 1-hour evaluation. Some people do 40 minutes and it kind of varies place to place, but really, we're going into a lot more detail than a lot of other people do for a lot of things, because some things are, if you have pain in your elbow, that's kind of easy to just say I've got pain in my elbow, but there's a lot more behind a lot of the psychiatric illnesses and struggles that people present. So looking at the mental status exam, some of the different things that we're observing in patients, So what are the main observations that we make? How does the patient look? Are their clothes messed up? Are they wearing appropriate things? How are they speaking? Are they speaking really fast, pressured speech? Are they looking all around, can't make eye contact with you? Are they fidgety? And then we're looking at their mood. How is the patient coming across? Do they appear really anxious? Do they look sad? Are they oriented to what is happening? Do they know where they are, what they're doing? Are they having delusions, unreal thoughts? They're not able to tell reality from not. And then their thought content, are they having these violent thoughts of harming themselves or others? And what is their insight and judgment like? So insight is how aware are they of, whether they have a problem or not. Some people might believe that they are being followed by the cops and they're very paranoid, but if they believe it's true and they don't see any problem with it, they don't have much insight to what their problem is, and it's harder to provide someone with care if they don't think that they need it. And then what is their judgment like? Can they make right decisions to take care of themselves and to do what is best? Something to note is that I work in outpatient psychiatry, so that's kind of more what all my presentation is kind of focused about. Inpatient psychiatry is, I'm sure, a whole different ball game, and things are a lot different. So oftentimes I'm seeing patients in the outpatient setting, either they previously were in the hospital or things have never gotten to the point where they have needed to be hospitalized. And things are obviously different when you're in a good state and your symptoms aren't that severe. But when things are to the point where you have to be hospitalized, symptoms are really severe, and a lot of these things can be a lot more difficult to manage and to really perceive as easily as somebody who is willingly sitting in front of you, who has seeked out your help from their own will. And then, after we do our general history and physical, we go into, making an assessment and plan. What did we gather from all of that information? And really, we look at things using the biopsychosocial model of health. So what are these 3 different aspects that we can look at, and how can we address all of these to help this patient? So biopsychosocial, so biological, does this person have any underlying medical issues that could be causing or worsening these symptoms that they're feeling? Are they taking medication? How is this medication working? Is this what they should be taking? Do they have side effects from it? Psychological, how are they with coping with their disease? How do they manage it? Are they seeing someone for therapy? Is that something that they could benefit from? And then you got to look at social aspects of patients. What is their support system like? What is their job, or what do they do for school? How much of a stress is this on them? What changes can you make to help them out better? So we look at all of these different things and see what we can fix in all of these different aspects to help a patient out with their symptoms. So I think that's kind of the general in terms of history and physical for psychiatry. So before we get into the cases, any questions, I guess, in terms of maybe perhaps what makes psychiatry a bit different from seeing a patient in another setting, or anything related to the things that I recently mentioned?
Yes, absolutely. So we've gotten a ton of really good questions. Let's see if I can find some that are pertaining closer to what you were just talking about.
Yeah.
So Sophia is asking about how difficult it is treating patients in inpatient psych versus outpatient psych. So if you're working in inpatient, sorry.
Right. And so as I kind of mentioned, so I don't work in inpatient psychiatry, and I've as I said, where I work now is where I did my rotation. So it was just outpatient psychiatry. So personally, as a PA or as a PA student, I don't have experience with patients in psychiatry. Experience that I do have with inpatient psychiatry patients is from back when I was a patient care technician in the hospital. So I worked on the general med surg floor, and occasionally we would get inpatient psychiatric patients that were transferred to our floor because while they were admitted inpatient for a psychiatric reason, they had a medical issue come up that they needed to be on the general medical floor for. Now, at that point, I wasn't in PA school. I just graduated from undergrad, so I didn't have a lot of the information that I have now, and I didn't know anything really about psychiatry. So that was a bit of a different outlook from it. But even still thinking now, I think personally, I haven't done it, but I think inpatient psychiatry is probably a lot more difficult. As I said, if you have someone who is hospitalized for a psychiatric reason, if they're being hospitalized, oftentimes it's because they're a danger to themselves or to others, or they're just not really in the right mind, and it can be hard to ask all the questions that you might be able to ask someone in an outpatient setting who is having less severe symptoms, able to cooperate with you more. So you have to really try, I think, a little harder and find different ways to get answers to things. And one thing I was mentioning that I think is really difficult about inpatient psychiatry is you really see patients when they're at their worst. When they are in the hospital, when things have gotten so bad that they had to be hospitalized, and your purpose is to get them stable enough where they can leave, but then they leave and you don't really know what happens to them. So I get to see patients who have either been discharged from the hospital, so they were good enough to leave, or they've never gotten that bad that they had to be hospitalized. And I get to see them through the months, through my care with them, and see them get better. And that's one of the things that's really rewarding, I feel, about being in outpatient psychiatry in general.
Yeah, that's amazing. Thank you so much for that insight. It definitely sounds like rewarding work. We've had a couple of questions on the next topic, so basically people are just wondering, for you personally, do you treat more on the therapeutic side, or do you generally go more the medicinal route?
Right. So we, as providers, as PAs, so as I said, my first visit with patients is an hour, so we really get a lot of information, and we are not therapists in the sense that with my follow-up visits, really they're only about 20 minutes for follow-up, and usually for most patients we're seeing them depending on how much their medication needs adjusting, maybe once a month. More stable patients once every couple months. And it's not like we're just it's not like I'm just how's your medicine, okay, what are your side effects, what are your symptoms, looking at it in terms of just adjusting the medication. Of course, you have to provide some of that support, and asking about what sort of stressors are going on in life, and trying to work those things out with patients. But that's not going to take the place of say a therapist that they might see on a weekly basis for an hour. So certainly, we talk about, different coping skills and different ways that patients can, things that they can put into their lives to make things better for themselves. But certainly in that short amount of time is not quite at the level that, say, something like therapy itself would be.
Awesome, thank you for that. And so I believe the remaining questions are more on the general side, or you may answer them indirectly in your case study. So if you want to continue with that.
Okay, yeah, so I've got kind of like two case studies where we kind of go into a couple different things in psychiatry that are pretty pertinent. And so a lot of the things that we talk about in psychiatry, as I said, obviously not a lot of people go into psychiatry. 1.5% of PAs are in psychiatry. So even, students who are on rotations or things like that, they might think that psychiatry is, not something they're interested in. It's not really something that's important to them. But, no matter what you work in, everybody has mental health that needs to be taken care of. And just because you are not in psychiatry itself doesn't mean that you're not going to come across a patient in whatever field you're working in that is having a really bad day, who is struggling in life and who needs support. And it's something that I think everyone really needs to be mindful of, and thinking of patients really not as just medical issues that need to be solved, and really looking at the person as a whole and what can be done for them in general. So the first case study. So this one's a little more forward in the sense. So we have a 28-year-old female presenting to your office with a chief complaint of anxiety. For the past year, she endorses worsened anxiety about several aspects of her life. She worries about her health, about something bad happening to her family while she's not with them, and about not doing well enough at work, among other worries. She's suffering from insomnia, is irritable towards her husband, and finds it difficult to focus on anything else but her worries. She is now arriving late to work due to her poor sleep. She denies depressed mood. She has no suicidal ideations, no psychosis or mania, and no history of any substance abuse. In terms of medication that she is on sertraline, 50 milligrams daily. So that's an antidepressant that was started by her primary care provider a week and a half ago, which she feels like hasn't really been helpful yet. She doesn't have any significant past medical history. She's never been on any psychiatric medication or sought help for any psychiatric issues in the past. Her mom had anxiety, she thinks, but it was never treated, so she's not really sure about it. She drinks alcohol socially, and she works in the human resource department at the local school district. With her mental status exam, it's unremarkable, but you do notice that she is in a really anxious mood and kind of fidgeting in her seat. So not a lot of other things going on in terms of factors that could be really interfering in terms of past medical issues, but obviously the patient presents with a lot of anxiety that she's been dealing with, and it seems to be really affecting her life. So, obviously, as I say, when I see a new patient, I spend about an hour with them, sometimes a little less, but, things would get into a lot more detail than this short little paragraph that I wrote here. We go into a lot more details, and insomnia. Well, tell me more about your sleep. Is it just difficulty falling asleep? Are you waking up a lot through the night? How does that affect your energy? And talking about a lot more deeper things. But for the sake of getting through the case faster, that'll kind of sum it up. So we try to think of the different things that could be going on. So while we're going through the history, taking the information that we're getting out of the patient, we're starting to think of all these different things in our mind that this patient could be currently dealing with. You want to try to, in any sort of specialty in medicine, keep an open mind into what it is that could be going on. If you from the beginning have your mindset that this is what this is going to be, you might not open yourself to exploring other areas that might lead towards something else. So you want to make sure that you're always thinking about a couple of different options that something could fit under. So this patient's really anxious. They're really struggling with a lot of different things, having a lot of symptoms like trouble sleeping, a lot of worries. Their work is starting to be affected because they're going in late. So what are different things that this could be? Is this depression? She didn't know that she had a depressed mood. She's not having thoughts of harming herself. Maybe not quite exactly that. Possibly hypochondriasis. So the patient mentioned that she's really worried about her health. Could this be illness anxiety disorder? So where you worry that something's wrong with you, even when there is really nothing to be concerned about. But it seemed like she was kind of also concerned about other things. She mentioned her family. She mentioned different stressors. So it doesn't seem like it's just related on the illness. So generalized anxiety disorder. This kind of seems like, she is worried about a lot of different things. It's been going on for a long time. It's not about one thing in specifically. Could be that. Panic disorder, really anxious. She didn't mention having any panic attacks. Would be something you'd probably want to ask about, but this patient didn't seem to have those symptoms. And then adjustment disorder. So adjustment disorder, kind of exactly what it sounds like. There's been a big change in life, and it's been not too long since that happened, and the patient is responding to that big factor that had happened. So it helps really knowing the specific criteria for all these different ailments, and upon further talking with the patient and narrowing things down, we decide that the best diagnosis for her is generalized anxiety disorder. So generalized anxiety disorder. So in psychiatry, we diagnose these different disorders using DSM5 criteria. So the DSM5 is the diagnostic statistical manual for psychiatric illnesses. So this is the psychiatry sort of Bible of every single psychiatric disorder. In this really big book has all these specific criteria that must be met in order to be able to be diagnosed. So this is what psychiatrists use to diagnose things. So this is the DSM-5 criteria for generalized anxiety disorder. So generalized anxiety disorder is when someone has excessive anxiety and worry for more days than not for at least 6 months about multiple events or activities. They also have difficulty controlling their worry, and they have 3 or more of the following symptoms: restlessness or feeling on edge, easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance. So our patient in particular said that she was having trouble concentrating. She was irritable towards your husband, and she was also having insomnia. So that fits the 3 symptoms in the criteria. And then the bottom 3 criteria are criteria that fit almost, or that are part of almost every diagnosis in the DSM-5. So in order to really be diagnosed with something, the symptoms have to cause significant distress or impairment in social, occupational, or other areas of functioning. So, you know, we all get sad, we all get anxious. Just because you're sad doesn't mean you're depressed. Just because you're anxious about something doesn't mean you have generalized anxiety disorder. Just because you feel like you have certain traits where, you know, you need things to be very organized doesn't mean you have obsessive compulsive disorder. So these symptoms really have to cause significant distress in functioning of someone's life. So, you know, not able to you know, do your work properly, doing not well in school, your relationships are being impacted by these different things. Also, the symptoms have to be non-attributable to physiological effects of a substance or another medical condition. Someone with schizophrenia, you know, they are experiencing hallucinations, delusions, they're paranoid, they're, you know, seeing things. You cannot diagnose someone really with schizophrenia if they're also taking a lot of different drugs, because you don't know if they truly have schizophrenia, or is this just something that is being caused by the different substances that are being used. So you have to make sure that it's not due to another substance or another medical condition. You know, one thing that we see in a lot of elderly people, they can become kind of delusional at times. And one of the biggest reasons that they become delusional is because they have a UTI. And that's just something that happens with older people. It doesn't mean that that person has a delusional disorder or they have a psychiatric illness, because it was actually attributed to a medical condition, the UTI. So we have to make sure that there's nothing else going on that could be causing these symptoms or worsening them. And then it has to be not better explained by another mental disorder. If you look at the definition for adjustment disorder, it almost is exactly the same as generalized anxiety disorder, except it hasn't been going on for 6 months and it resolves within 6 months of the stressor or event. So you might say, you know, if a patient has been dealing with something for 3 months, how do you know it's not generalized anxiety disorder, but it just hasn't reached the 6-month mark? So those are, you know, little tiny specifics that, you know, you will find that not every patient will fit an exact criteria for something, and some of that will take your professional judgment in, you know, deciding whether this fits the criteria or diagnosis or not. So we decided that this patient has generalized anxiety disorder. So what are we going to do? So if you remember, I kind of mentioned the biopsychosocial model. So we're going to look at these different aspects of the patient. So starting out biological. So the patient went to see their primary doctor, but they didn't get a full physical. They really just went in for this one complaint, and they were started on medication. But they didn't do anything else at the visit. It was a short visit. So we want to make sure that there is, you know, no underlying medical issue that's going on that, you know, could be worsening these symptoms or causing more issues. So we want to recommend that they get a physical, and we want to check some blood work. So, you know, complete blood count, check a metabolic panel, check thyroid levels. Sometimes hyperactive thyroid can cause a lot of anxiety. It makes your heart beat faster, make your metabolism go faster, so that can cause symptoms that feel like anxiety. We also will often check vitamin D, just because low vitamin D can be associated with a lot of different things. And oftentimes, there isn't anything underlying medical going on, but you just want to be thorough and make sure that you are crossing all your T's, dotting all your I's, making sure there's nothing else that could be an issue. So with the medication, so she started it a week and a half ago, but she is upset. It hasn't done anything. She doesn't feel any better. She wants new medication. She wants some change. So I would suggest that you just keep the medication as it is. Continue it at 50 milligrams for a couple more weeks. The unfortunate thing about antidepressants and a lot of medications in psychiatry is that they can take a bit of time to work. So with most antidepressants, we tell patients they have to take them for at least a month before we can really assess if they're going to be helpful. Doesn't mean that patients don't notice anything in a week or two, but after a week, if they haven't noticed anything and they want to stop it, they haven't really given it the full time to see if it's going to be effective. And it can be really easy to want to make changes faster because you want the patient to do better. Well, let's just increase the medicine so it works more. But you also don't just want to keep making medication changes and end up giving a patient more medicine than might be needed. So always remember to be patient and take things one step at a time. But then we might also consider medication on an as needed basis. Does she need something else to help with sleep? Does she need something for severe anxiety to help her calm down in the moment, especially as we wait for the medication to kick in? Kind of depends on the patient. So what about her psychological perspective? We want to encourage the patient to do therapy if she can. Oftentimes medication can help with those physical symptoms, but therapy is really going to help with learning those coping skills and those mechanisms that are going to help down the line, because life is stressful and there's always going to be something else difficult that comes along, and that's going to be more helpful in the long run. And then looking at her social aspects of her life, she works at a school. What is the environment like there? Is she able to kind of take a bit of a step back from things? How are her friends? Does she have family that is supportive? That'll make a big difference in making sure that she's able to take the time for her recovery. So we'd continue the medicine, we'd encourage the therapy, and we'd check the physical and blood work, and we'd tell the patient to follow up in either 2 to 4 weeks, depending on how severe her symptoms was. If I was more worried and would want to follow up more closely, I'd probably say 2 weeks, especially to make sure that at that point the medication was making a difference. Or if she had been seeing improvements already, probably would say about a month, or with starting medication too, usually about a month is how much time we give, just because that's really how long it takes to see how the medication is going to be working. So I think that's it for the first case study. Anyone have any specific questions about that?
Yeah, we did get a couple of specific questions. There were actually quite a few, but you did a really good job of answering them as you went along. So we'll try and not make you repeat yourself. But Brianna is asking, is GAD the most common disorder that you treat?
So I'd say it's probably about a tie. With the most frequent things I see are probably depression and general anxiety. Definitely in terms of outpatient management, those are the most often the new patients we see. And then probably followed by a good amount of patients who have ADHD and bipolar disorder, and then everything else kind of comes after that.
All right, thank you. Adriana is asking, could you please explain why a UTI would cause delusions?
Yeah, so I am not exactly sure again with the mechanism of exactly how that happens, but it is probably the most common cause that if you have an older person who suddenly is just not really acting right, especially someone in the hospital, because UTIs are big infections that often happen to patients who are already hospitalized. That's always the first thing that you want to think of. Obviously, younger people have UTIs, and that's not something that happens to them, but it is something that happens with older people, and oftentimes they also don't get fevers with their infections either. So it's just a different response they have, but I'm not quite sure exactly how the mechanism works with it. And I'm not sure that it's really well understood as well.
That's really interesting. It seems like something that'll keep you on your toes, kind of that indirect relation. That was really cool. But Caroline's asking, say someone does fit the DSM-5 criteria, how would you approach their diagnosis? And do you generally start off with a holistic approach?
Yeah, so so every patient has their own ideas in terms of do they want to take medicine? Do they want to do therapy? Do they just want to do one or the other? So in this particular case study, the patient was had already been started on medication, but when somebody does come in general for the first time, we tell them, obviously you're dealing with a lot of anxiety, and these are the different things that could be helpful. So we would present different options for medication, something like a daily basis, like the antidepressant, like sertraline that was used in the case as a daily medication. But some people don't want to be on medication, and that is totally fine. I am here to present options for the patients and not to push medication if that's not what they want. Some patients choose to just try therapy for a month or two and see if that makes a difference. Some patients, for a variety of reasons, they don't have the time, they can't afford it, they don't want to, won't do therapy, and they just want a medication that will help them. And while we always encourage both of those as options, and different life changes that can make changes, more exercise, eating healthier, better sleep hygiene, they're all things that are encouraged, but ultimately we really put that final answer in the patient's hand and how they want to proceed with things.
Great point. Thank you for that. Let's see. So Teal is asking, when you order blood work, if you were to get abnormal results, would you refer them to their primary care before continuing care, or do you make the judgment on when to proceed?
Yeah, so as I kind of mentioned, oftentimes there isn't something else that's going on. So when it comes to something like, say we're looking at the anxiety, so I would probably, had the patient not been started on anything, I'd go ahead and start something like sertraline even before we get the blood results, just because sertraline is a very mild medication, and if there is some other issue going on while that gets taken care of, this will help with the symptoms that they are dealing with. If they did have their thyroid did come up too high, and maybe that was part of the reason, then we'd continue the anxiety medication, but I would tell them, you need to follow up with your primary care doctor, because this could be the reason for your anxiety. And then once that's under control, then we could see if maybe they didn't need the medication anymore.
Perfect. Thank you for that. And this next one is an interesting question. So Eden is asking, what vitamin D level would indicate a biological assessment for GAD, given that a deficiency in vitamin D is common? And so in that, I know 30 is on the low end of the spectrum, but would you wait until it crosses the threshold into like the 29 and below? Or do you think if they're close enough to 30, then you should start treatment on that?
Yeah, so that is Interesting that you mentioned, because I forget that, everybody is from a different area. I know you guys mentioned you were in a much warmer state, but so here I'm located in Chicago, so just about anyone that we test vitamin D in usually is deficient in vitamin D, because it's really cold here a lot and people are not outside. We don't have a lot of sun out all the time, so people just don't get the vitamin D that they need. So most people do need vitamin D. We usually, when it does come out low, I do tell patients to talk to their primary care about it, or just start taking an over-the-counter supplement. The vitamin D itself, it's oftentimes not the main source of all the anxiety and the issues that a patient will be presenting with. But things like, vitamin deficiencies can present with a lot of general side effects or general, issues that come with it. So overall, if you're low on vitamin D, you should probably take a supplement. It's going to help more than hurt if you're low on it.
That's a really good point.
Wow,
Thank you for
yeah.
making that, because, I would never think that the geography of, the different states makes a difference. But
Yeah, we all have low vitamin D.
Awesome. So I think one more question on this case study, and then if you want to continue to the next one.
Sure.
But so Heather's asking, I know when you were talking about the most common disorder set you treat, you mentioned bipolar disorder, and she wants to know if it's most commonly type 1 or type 2. And if you place a big emphasis on major depressive disorder versus persistent depressive disorder.
Yeah, so in terms of what I see most often between bipolar 1 and 2, it's probably bipolar 1. Most cases of patients that I see who have bipolar disorder have already been diagnosed in the past. And typically once you get a diagnosis, it kind of just sticks for the most part. But one thing that is interesting that you mentioned, difference of, this diagnosis versus this diagnosis. Sometimes it is hard to really pinpoint someone's exact diagnosis. As I said, not everything is black and white. One person might fit things here, things there. And sometimes people can get really hung up on, what is wrong with me? What is the issue that I am dealing with? And sometimes it's hard to really give an exact, answer to that. What I often tell patients is, what we're going to focus on are the symptoms. We might not be able to say, do you have severe bipolar disorder with psychosis versus schizophrenia? Maybe I'm not sure, but it's going to be the same medication, whatever it is. And if your symptoms are under control and taken care of, we might not be able to say, what it is that is going on, but you're doing okay. So, that's the best we can do for now. Similarly to, kind of major depressive disorder versus like a persistent depressive disorder, dysthymia, it's also called. What are we going to use in probably both of those situations for big symptoms that won't go away? An antidepressive. So, it's sometimes these different names of things really, I feel like in the long term, sure they're important, but what's most important is that we're managing whatever symptoms are presenting themselves.
Awesome. Thank you so much. And I think that was the final of our questions regarding this case study.
All right, so we will go to the next one. So this is the only other case study I have, but it kind of breaks up into a couple parts. So we have a 60-year-old female patient with a diagnosis of major depressive disorder for the past year. Despite multiple trials of medication, she continues to report significant symptoms of depressed mood, anhedonia, so lack of interest or enjoyment of things, poor sleep, low energy, feelings of worthlessness and hopelessness, crying spells, lack of motivation, and passive suicidal ideation stating, "I just wish I would go to sleep and never wake up." She has a history of diabetes, hypertension, hypothyroidism, and all of these, as of now, are well controlled with medication. So you don't think they will be contributing to anything that's going on. Past psychiatric history, she reports she dealt with depression after 2 of her children were born, postpartum depression. She was living in another country. She didn't get any treatment for it, but eventually both of the times they got better. No relevant family history that she's aware of. She has been a stay-at-home mom, a homemaker her entire life, never use of any substances. And upon a mental statics exam, the patient is disheveled, noticeably anxious and in a depressed mood. She has a constricted affect, so not very much of a range and variety of emotions in her voice and presentation. She is fidgeting, restless, and in regards to thought content, she endorses passive suicidal ideations without any plan or intent to act on it. She also has poor insight. She's not really sure what she can do to improve her symptoms and doesn't feel like she can do anything to make them better. So this, unfortunately, is something that sometimes we come across, patients who show up with a huge list of medications that they've been on, which, you know, for whatever reasons were not helpful, whether it was due to a side effect, whether it just didn't work. You know, maybe they didn't stay on the medication long enough or go on high enough a dose to really see if it was something effective. And a lot of times it's just kind of gathering all this different information and trying to figure out, what is another medication or another option that we can provide this patient. So this is actually a real list of medications that I had from a patient in the past, of all the medications that they had tried that hadn't really worked. So fluoxetine, an antidepressant, amitriptyline, a tricyclic antidepressant. So these are some of the first antidepressants that were ever used, not really used anymore because they have a lot more side effects, and patients can actually overdose on a week's worth of these types of medications. So the newer antidepressants are a lot safer for use. Quetiapine is a second generation antipsychotic medication. Antipsychotic medications are often used in things like bipolar disorder, schizophrenia, psychotic disorders, but also in treatment-resistant depression and anxiety. Citalopram, another SSRI, serotonin reuptake inhibitor, antidepressants. Rexulti, another second-generation antipsychotic for treatment-resistant depression. Sertraline, another antidepressant. Lorazepam, paliperidone, 2 other second-generation antipsychotics, and mirtazapine, another antidepressant that works in a bit of a different mechanism than the SSRIs, working on different receptors. So this patient in particular had tried all of these medications, weren't exactly sure of all of the doses. She had really seen little to no success in any of her symptoms, or she did see some improvements, but after a bit of time, she was back to how she previously was. So what do we do when a patient has gone through a lot of different medications, or at what point do you start thinking about other options? How many medications do you go through? So what's interesting enough is treatment-resistant depression. The actual definition of it, which is not exactly the only definition. A lot of different sources cite it differently, but treatment-resistant depression can be described as depression that doesn't respond to 2 trials of monotherapy antidepressant treatment. So if a person has already tried 2 medications and they didn't work, you can already consider them under the treatment-resistant depression category, which is, not a lot when you really go into psychiatry. Sometimes you see that, it's not uncommon to have a patient who has been on a lot of different medications or is on multiple medications at once. So, what do you do in a situation like this? Do you try another medication that they haven't tried? You could, and you have to wait about a month to see if the medication really makes a difference. So it's a tough situation, and there's no right answer, and something you have to talk with the patient about. There are other options to treating depression than just a medication. In terms of treatment that we can do, I'm sure we've heard of electroconvulsive therapy, which was a big thing that was used in the past. So it's actually still done to this day, in a lot more humane ways than it was done in the past. So patients get put under anesthesia, and they have seizures stimulated in their brain under anesthesia, and it can be helpful for depression, severe bipolar disorder, and patients do see improvements from it. There's also a more newer sort of procedure called transcranial magnetic stimulation. So it's kind of a similar idea as the ECT, where you're stimulating different areas of the brain, but this is using magnetic waves, kind of similar to an MRI, as you can see in the picture here. You place it in these different areas that are hitting different parts of the brain, and it helps people with their symptoms. There's also other medications. Ketamine or esketamine is sometimes used for treatment-resistant depression. Now, these medications have to be administered at a facility under the supervision of a medical provider who is approved to give these specific medications. So ketamine infusion is done through IV, and a newer version of this, esketamine or Spravato, the brand name, recently came out just a couple of years ago. And so this is actually a nasal spray, kind of like the allergy sprays that you just spray into the nose. But again, this has to be done in a medical clinic under the supervision of someone, and patients usually have to be monitored for a couple hours after the nasal spray or the IV infusion to ensure that they don't have any physical reactions or any side effects to it. But these are other options that exist. They have a lot of variance in terms of insurance coverage, whether this is something that is affordable or possible for patients. And then kind of moving away from the medication side, there are, we talked about the therapeutic side of things, what we didn't mention if this patient was in therapy or not. There are more intense programs than, what if a patient, they don't need to be hospitalized. They're not a threat or danger to themselves or anyone. They don't need to stay overnight at a hospital, but they need more than, a visit every few weeks to see how they're doing. So there are programs that different facilities offer called partial hospitalization programs or intensive outpatient programs, where patients will go to these programs maybe multiple times a week from, say, 9 to noon or 9 to 1, and they get a lot of therapy, get group sessions, a lot of these things that they would get on an inpatient basis, but they're able to do it from home and go home at the end of the day, because really they don't need to be in the hospital, but they are able to achieve a higher level of care than just someone looking at their medication every few weeks and seeing a therapist maybe once a week for an hour a week. They get a bit more than that. So that's kind of the first part of that. If anyone has any questions in terms of dealing with any of that and kind of a lot of medication and things that are a little more difficult.
Yes, so we did have a few questions on that, mostly about the extensive medication list that she had. But so Anne is asking, what is your opinion on polypharmacy and how to address that issue, especially in older patients such as the one in this case?
Yeah, so with polypharmacy, so this patient wasn't on all these medications at the same time. I guess I didn't say that, and I didn't notate what medications the patient was on at the time. I think she was on probably on 2 or 3 of them at the visit that this would have been. We always, at least at our clinic, we really aim to use the least amount of medication as possible. So if you can use less different medications, that's always best. There's always less risk of interactions with different medications. So you always want to get the most that you can out of one medicine before you add another one in. So you want to get to the max dose of one, and then depending on the situation, you might decide to switch a medication for another one if it's not working well enough. Or sometimes you do add in something to help. It's all kind of an individual basis, but you always want to try to reduce the different factors that you have going on with the patient, so different amounts of medication.
Okay, perfect. Thank you for clarifying that, because I also thought that she was just on all that stuff.
Yeah, no. Yeah, I realized I didn't make that clear now.
Oh, you're good.
So Rochelle is asking, do you have to learn all these medications during pharmacology in PA school, or do they cover more general popular medications that you need to know?
So let me go back here. So yeah, I probably learned these all in PA school in pharmacology, but on a much more of a surface level. So fortunately, a lot of them sound really alike. So if you can see, so looking at the 2nd generation antipsychotics, so on the bottom, you have lorazepam and paliperidone. So a lot of these types of class of medication ends in that sort of done sound. Risperidone, the quetiapine up here is a little different, but for the most part, they all kind of sound the same. Same for, sertraline, fluoxetine, a lot of these different medications, amitriptyline sounds like nortriptyline. So there's not a lot of different categories of medication in psychiatry. So really what you learn is the category and the general sort of side effects and what they do. So I knew, the specific things that you had to know, like say, this particular SSRI you don't want to use in this patient with this contraindication or things like that. But in general, and kind of for most, in general, like pharmacology, you really learn things in terms of the classes and what makes everything fit under categories. And then I think as you go into rotations, and especially whatever work you get into, you really start to learn the specifics of the medications. Like it's really interesting to see, a lot of patients, if they're on more than say like an SSRI, their primary care provider often will just refer them to psychiatry because they really don't know too much about the specifics of psychiatric medications, and that's fine. They know their kind of first lines that they got to do, and then anything else they kind of send over to us. So you don't have to learn quite all the specifics of all of them for pharmacology.
Still really impressive. Like, that's so many medication to know, and it always blows my mind like how, like, that vast knowledge that you guys have of like all of these different things. It's really crazy.
Yeah, I don't know how we do it.
So these next two questions kind of go together, so I'll just group them together. But Hassan and Jennifer were asking about the alternate options that you mentioned. So the ECT and the TMS and that kind of stuff. So Hassan is asking, how often are those utilized, and are they more so avoided? And then kind of piggybacking off that, Jennifer was asking, do they have any major side effects?
Yeah, so it's not super common. I can't really think of, I think I can think of like 2 patients that I currently have that might have done ketamine infusions. I can think of 1 patient who does ECT. Not sure, TMS, I know people have looked into it. Again, as I kind of mentioned, a lot of it is like the TMS and the ketamine, it can be very expensive, and a lot of times insurance won't want to cover it. So that's certainly something that not everybody would be able to do. And by expensive, I mean like maybe $2,000, $3,000, and there's no guarantee that it's something that's going to be helpful. In terms of effects that can comfort, so the ECT, I mean, you're doing, making seizures happen. So there, are issues that can come with that. Obviously they do what they can to make things safe. There's risks with any procedure. TMS, really the only side effects oftentimes, unless of course you already have seizures or things like that, which you wouldn't have any of these to begin with. But really the biggest side effect is people say they get a headache, probably because they have to wear this helmet thing. And then the ketamine, esketamine. So those can have side effects, which is why they have to be administered directly in the care of someone, and you have to stay there for a few hours because you can't have issues with your blood pressure and your vitals and things like that. So they do have to be more monitored more closely. So again, these aren't super common, but they are things that are out there. And then we don't do any of these at our clinic, so they're things that we would refer out. So I don't know too much about the specifics of how these actual procedures are done.
Okay, so on that subject, this next question is a little bit more wordy, but it is interesting, so I'll try and ask it to the best of my ability. But Eden is asking, if a panic patient falls under treatment-resistant depression and TMS is used, would you prescribe the patient with an anti-anxiety medication beforehand, given that TMS causes increased anxiety? Or would you wait for the patient to exhibit anxiety and then go forward with the prescription? And how would treatment resistance play a role in this given situation?
So in terms of anxiety, I believe TMS, I'm not sure if it's used for anxiety as well, but if somebody was not experiencing anxiety, would I give them something for anxiety if it might cause anxiety? I wouldn't give anyone medication in prevention of something, again, just because we want to use as little medication as possible. So if we're going to be using something in terms of, say, a daily medication for anxiety, if we start a medication and the patient doesn't have anxiety, well, was it because we started the medication, or did they just not have anxiety at all? And so that's kind of tricky to tell the difference from there if we have different factors that have been involved. But also, if the patient already had anxiety and, they were worried about the thing, maybe we'd give them something on an as needed basis to take. If you do start to feel anxious after it, you can take this and it'll make you feel a bit more calm in the moment. And then we can follow up and see how you were doing after that.
Awesome.
Wow, thank you. You really answered that question really well. Brianna's asking, are you ever worried that people are exaggerating their symptoms they tell you about so that they can get or keep their prescriptions?
No, I'm not. Well, oftentimes, the medications that, people might try to take more than not are usually medications that are controlled substances. So things like benzodiazepines, so like Xanax, lorazepam, those types of short-term anxiety medications. So something that would be kind of on an as-needed basis. So I actually, in general, steer away from those medications. I try to use them as little as possible because, and I think that's the general consensus in psychiatry nowadays. I think they were very much overutilized in the past, and now we are realizing all of the issues that can come with them. Patients do become dependent on them. They lead to long-term use, leads to higher risk of depression, memory issues, and people can really become addicted to these medications. So, I personally try to prescribe them as little as possible. And I also let patients know that this is a short-term solution and it's not something that we're going to be doing for a long time. And then I will, if nothing else is helping and that is the only thing, we try to push towards other more safer treatment options. Probably the other type of medication that might be have the possibility of being misused or abused are stimulant medications like Adderall or similar medications like that, Ritalin. And again, it's just, you don't want to be super cautious of everyone who is on these medications because some people really do need them. There is someone every now and then who probably will try to get medication that they don't need, but you just have to, get to know your patient and build a relationship and get to know them. And overall, I feel like something I think I worried more about when I was starting out. But as I've gotten more comfortable, I feel like, you have to be able to trust your patient. And if you don't trust them, then you shouldn't, or, maybe can't provide care for them, and maybe they have to go somewhere else.
Yeah, that's really good input on that. That's kind of one of those gray areas of medicine.
Right. It's sort of, up to you, what you think is right or wrong to do.
Yeah, absolutely. Couldn't have said it better. But I think that was the last one regarding that case study. So if you want to continue, feel free.
Okay, so kind of last thing I'll just touch on here is the patient mentioned some suicidal ideation. So thoughts about, not wanting to be alive, but she didn't necessarily say that she wanted to do anything, nor did she have plans to do anything to harm herself. One thing that we can always talk about with patients who might be at risk, to harm themselves, but obviously if she was really at risk, we would refer her to a hospital or call 911 or, make sure that she's in a safe place. But we can always talk about a safety plan with someone. What are the things that they can know that when they start feeling worse? Who are the people they can reach out to? And really just going through this with the patient makes it easier for them to have these different things on hand, and having that available when you are in a moment of crisis or in this deep moment is easier to access than, trying to think of everything at the moment. So that was just a final note I wanted to make about that. And you can just Google a safety plan, and it kind of goes into, the things that are important for someone to have on hand, and something that could be important again in any aspect of life, dealing with any patient who might be struggling or have the potential to have an emotional crisis. And then, so that was kind of my last note. In general, mental health care is relevant for everyone, no matter what you do or whether you're in healthcare or not. We all have to take care of our mental health. Don't feel discouraged. I know applying to PA school and comparing yourselves to other people and everything can be really difficult. But don't be scared to apply. Keep your mind open to the programs that you apply to. As I said, I went to a new program and I loved it and I had a great experience. And here I am as a PA, and also keeping my mind open in what field I wanted to go into. I didn't think I wanted to do psychiatry, and again, here I am loving it. So just always have your mind open about different things and look at all the options you have. And with that, I think we'll just open to general questions and then wrap things up from there.
All right, awesome. We have amassed quite a few general questions for you. So I guess just first and foremost, how are we doing on time? I want to make sure we're respectful. We don't want to keep you here all night or anything like that.
Oh, I'm fine.
Okay.
Yeah, okay.
All right, perfect. And kind of on that note, would you be okay if we linked your Instagram on here just in case people want to follow or ask you questions? Okay, perfect. So we'll put that in the chat for you guys in case your question doesn't get answered, or if you want to reach out to her, follow her Instagram. Highly recommend. We follow her ourselves and it's awesome. Oh, and yeah, thank you for the meme. We appreciate that. That is, everybody needs that right now for sure, especially all of us PPA students. And what you said about the forums is so true. I feel like every time I'm like, yes, like this is happening, we're doing good. I jump on the student doctor forum and I see everybody else's stats and I'm like, oh God, I should just give up.
I have 5,000 hours. Am I good enough?
Yeah, definitely.
And just, look at all the stats that I shared. Like I was totally bottom of the barrel and here I am.
You're awesome. So thank you so much. But okay, so jumping right into it, Ava's asking, what about being a PA stood out to you more about medical school or more than medical school? Sorry.
Yeah, so as I said, originally wanted to go to medical school and just always had some sort of doubt to it. As I think I kind of mentioned, so going through my really big health experiences in my personal life, and I actually ended up having a recurrence again last year after I graduated PA school, so that further kind of threw my life for a loop and really reevaluating the, not just what I wanted for a job, but when I was younger too, what are the things that I want out of my life? And I knew that my family was really the most important thing. And I thought of, graduating college and going to medical school for 4 years. And what if I went to a school that was far away from home? Then what if I went to residency somewhere matched in another state? And did I really want to spend possibly 10 years away from where my family was? And then, spend life as a doctor, working whatever, super intense hours. And I just didn't really feel that intense commitment that you really need for medical school. But I still wanted to be in the medical field, but I knew I didn't want to be on the nursing side of things. I wanted to kind of be in the role of a practitioner, but so nurse practitioner was like really interesting to me as well, but I didn't want to be, again, a nurse first. That sort of just learning style or way of caring for patients just wasn't what I was looking for. So physician assistant just kind of hit everything in the sense that not that it doesn't require as much work as medical school, because the process is just as difficult in applications and the competitiveness, and the schooling is shorter. And really, I guess I had to be, you have to be comfortable with not being the number one in charge person, which was not something that was important to me, not being, at the top level of it. And just knowing that in the future, if I decide I want to be a mom or, maybe work part-time, if I was going to be a doctor, there's no way that I was going to be working part-time, because that was just like a waste of going to medical school. So this was just a good kind of middle fit for me.
Good point. Yeah, and there were a lot of good distinctions you made there. But let's see. So this one's good. Amber's asking what you liked and didn't like about Dominican University. She's actually looking to apply there next cycle.
Yeah, so I think it's probably difficult for me to say now because I'm sure things are so different at this point from where it was when I was in school, because so we were the first program, everything was brand new. In a sense, we were sort of the guinea pigs for everything, so they tried some things out that maybe weren't the best, but the good things about that is that the school was really receptive to our input and the changes that we had. I remember like the first week we said we really needed a fridge and a microwave because we had nowhere to put our lunch, and they got one. They got a fridge and microwave for us, so they were really receptive about the things that we felt we needed as students and the things that would help us advance. And so that was really great. I guess I'd say the only things I didn't like about it was those sort of hiccups that we had with being the first class. But I think that they probably, learned from whatever those mistakes were and have changed that for the future classes. So I think it'd be, really interesting to see how everything looks like for someone who's in class now today, because I know there's changes because they even changed some of the way that they formatted the curriculum and how they spread things out. So it'd be good to probably get a perspective of someone who is in the program right now. But probably the thing I loved most about it was that it's a small school, a small private school. It's a class of 30 people, and you're all stuck together in the same room with the same faculty members pretty often. So it did really become like a home, and everybody really knew each other and was very close with each other. And it was like a family. And that was probably the nicest thing about it. And you make really good connections. And I think that's really helpful with getting through PA school.
Yeah, that definitely sounds like a good dynamic. Let's see. So Anahi is asking, did you apply to PA school directly after your undergrad, or did you take a gap year?
Yeah, so I applied right after my undergrad. So I finished school in May of 2016, and I applied that cycle. So I submitted my application in like June, and I got accepted for the following January. So I had like a half gap year. Most programs start in like August. So had I gotten into one of those programs that started like in the summertime, I would have had a full year. But Dominican was just on a different schedule where they started in January. So I got to go in faster than I would have ever imagined.
Cool.
Wow, that's really cool. So Heather's asking, is the rarity in psychiatry because of the competitive nature of psychiatry, or just simply many people don't like the specialty, or they've never really heard of it?
I think, it's hard to say. I'm not really sure because I think in general, it's just not a specialty that has utilized PAs where obviously if you go to most like orthopedic surgery places, most of those places have PAs. If you go to most local family medicine, a lot of clinic places, a lot of them have PAs. I don't necessarily know why psychiatry hasn't had PAs. I mean, I think in general, psychiatry is a small specialty. There's a lot, I know in medical school to try to get a residency in psychiatry is really hard, and it's getting like smaller every year. So I think there's just not a lot of psychiatrists out there to begin with. And then that being said, there's then not a lot of jobs available with it. So I think there are people who look for it too, but just can't find a position because there's not a lot of psychiatrists.
Makes a lot of
Yeah,
sense.
interesting point. So Rose is asking, could personal experience with mental health issues and treatment be positive experience to add to a personal statement, or is that too risky?
Yeah, so that, it's tricky because I think that's a big thing that people kind of struggle with, even in the sense of medical professionals seeking care for their mental health. A lot of people don't want to because, they worry, somebody who works there or in the system will access their information. They don't want people to know that they have this. They worry how people will judge them for it, how it will look badly upon them. And, you want to say that, I tell this sometimes to patients too, regarding like their job and things like that. And kind of similarly to speaking from experience, in having told employers or future employers or not, whether I had cancer in the past, and that was something I'd recently dealt with. It's, you want to think that people are not going to have a certain look on something. And of course, it's illegal to, discriminate against people based on a mental or physical illness or disability. But in some ways, there's no way to really take away that bias. So it's something, to somewhat be careful about, because, if there's anything that might harm you, you don't want to take that risk. But if it's something that you feel like would make a strong statement, maybe testing things out and then having a couple people read it and see what their thoughts are on it and whether they feel like there's any risks or any issues with that.
Thank you for that feedback. That's really good input. So Jenna, is asking something that I think is very relevant to you. She is looking to apply to a brand new PA program. So she wants to know, what kind of advice would you give her? She said it's hard to gauge the quality of the program with no graduating classes.
Yeah, so I know, so that was one of the things that I, kind of worried about with, applying to the school and thinking, do I want to go to this school? So I know when I had my interview with them, asking them, what did they base their school on? Where did they, what did they model things after? And they actually pointed to one of the older PA programs in the country and how they kind of were following their model and where these different things were coming from, and just kind of seeing how everything really went in the interview process. And as I mentioned, I only interviewed at this one school. I had only applied to 3. I only got 1 interview. But talking to other students who were in my class who had interviewed at other schools, they just said that the experience that they had at the interview at my school was just very different to the experience at other schools, where they really got that feeling that that welcoming, sort of homey feeling, where they felt like the staff really cared about them, which I kind of mentioned was the thing that was my favorite part about the program. And a lot of other people really felt that from the interview and felt that that was where they wanted to go, which is why some people chose that program as opposed to something else, because they felt like, even though they didn't know, whether the program would be a success or not, they felt like they cared enough to put in the effort to make sure that we would succeed. And personally, as I said, that was the only school I interviewed at and I got accepted. So it was, do I go into this program that has never had a program before, or do I risk waiting till next year to apply? And then what if I don't get accepted anywhere else? So I just said, well, I'm in a school, I'm just going to take it. And it was a great experience, and I'm so happy I did. And you're not going to lose anything by applying to a new program like that.
It's awesome. Yeah,
Incredible.
it's kind of a unique, but also not so unique thing, because we've noticed that there's a lot of PA programs opening up. So
yeah, and I think you get a sort of vibe from wherever you go to, whether you interview with them or not, and I think that will kind of tell you a lot more than what you'll read on a website or something. What they put up. Are they actually put together and look like they know what they're doing at their interview day? So that'll kind of show a lot.
Yeah, good point. As much as it seems like you're there for the interview, you got to kind of interview them as well, right? Make sure they match you. Perfect. So Jennifer is asking, how much autonomy do you have in the office? Does the doctor normally go in with you and review every patient, like in regard to their medication, or do you usually refer to the MD only on cases where you need advice/assurance?
Yeah, so I think this really differs by a lot by state and what the PA laws are, and then really individually as well, based on the place that you work, and the freedom that you are given. So I work with my collaborating physician. He only works 2 days a week, and I work with him whenever he works. And I kind of provide support for him. So I get to, in a sense, see all of his patients and see what he does with his patients, and learn a lot from those interactions. But otherwise, I see patients on my own. There's patients that we kind of see back and forth, where since he is more busy, he will see, and then I kind of see in the in-between time, just to make sure things are going okay. And there are some patients that I see totally by myself that have never met him. So it really takes a good relationship, to do something like that. And you have to know what your limits are, and when to ask for help, as well as having that provider feel comfortable to give you that authority to make those decisions on what you feel like you can do or not. So if there is an issue, I will tell a patient, say, hey, I'm having a little trouble deciding what next steps we should take. I'm going to talk about it with, this doctor, and I'll check back in with you so we can make sure that we do what's best for you. And overall, it's not about, me not knowing enough or whatever it may be. It's just making sure that we do whatever is the best for the patient.
Right. Awesome. Big picture at the end of the day, right? Always best interest of the patient in mind. So just to check back in, are we okay on time?
Yeah, I'm okay.
Okay. So maybe like 5 more questions, if that's all right with you.
Yeah, that's fine.
Okay, awesome. This one's kind of just a general question for you. Hassan is asking, what's the most common misconception about outpatient psych?
I think, I don't know. I think maybe people, it's hard to say because I don't have an outside perspective because I'm in it, but maybe, I don't know, people think that I'm just seeing, patients that are really just struggling, and that it's just like sadness or depression, anxiety all day. But a lot of patients are doing pretty well for the most part, and it's if they're on medication, they just still have to check in and just make sure things are going good, and it's nice building that continuous relationship with the patient, and kind of checking back in with them and seeing how things are. But I don't know, I think it is something that it's not for everyone. Some people might find it boring, or being just in the office all the time, but it works for me.
Yeah, that's really interesting because like you said earlier, I think you're 1.5% of PAs that are in psych, so I'm sure there's a ton of misconceptions about it, like versus somebody like you who actually knows what's going on.
Yeah. And I'm sure it's just different. And so I work in private practice in outpatient psychiatry. So I'm sure it's, you know, different depending on what setting that you're in.
Definitely. This is a cool question from Emily. She's asking, how does being in a mental health career help you take better care of your own mental health?
Yeah, so you know, it's interesting because, you know, I myself go to therapy every few weeks. You know, I told my patients that, you know, therapy is something that everyone could benefit from. You know, we all have problems, we all have issues that we deal with, and you know, everybody can stand to benefit from taking care of themselves more. And one thing that I kind of started to realize is that, you know, I spend so much time, you know, at work with my patients, just really, you know, being empathetic and trying to connect with them and provide the support that I can, that I think I started to kind of turn that off on my non-work life. So I, you know, kind of turning my mind off and just kind of, you know, I did all my work in the day. I'm just kind of going to shut off now. So it's something that I've tried to be more mindful of, and remember that, you know, the people in my life, my friends, my family members and such, you know, they need support as well. And sometimes maybe it feels like it's just like part of my work, but it's just, you know, taking care of the people in my life too. So just trying to stay mindful of the things that, you know, we tell other people to do, and making sure that we're doing them ourselves.
Yeah, so kind of on that note, I know you have to find ways to kind of get your mind off of work and ways to deal with what you see at work. And so this is an interesting question from Anne. She says she saw that you mentioned that you treat mostly adult patients, but how would you approach the millennial and Gen Z sort of dark humor regarding suicide and death?
Yeah, so yeah, I know that is I mean, definitely a thing you see on the internet and such. That being said, I don't think it's something that has really come across into my practice. You know, I think when people are actually seeking out care, when they're in that moment where, you know, they're kind of talking to you, they're really vulnerable, and for the most part, that hasn't been something that's really come across. You know, sometimes people are a little bit more, you know, kind of not standoffish, but will kind of put a wall up and stuff and kind of try to make things more cheery than they are. But that hasn't been, again, too much of an issue in terms of something that I've seen actually in practice. Yeah, I see a lot of it like on the internet and stuff, and of course people make memes about things like that, and but not something I've had to really address. Again, maybe because I do deal with older patients, or not sure.
Awesome. Okay, so the takeaway is that memes are good and they're not the root of all evil, right?
Yeah, I think you know, people find coping through humor.
Yeah,
That's very true.
Sure. Okay, so I think this next one is a good one to end it on, if that's okay with you.
Sure.
So Jenna is asking, where do you see the future of psych going? It seems like the need for care is growing, but the resources aren't there to support it throughout the country.
Yeah, so that is, you know, something that obviously is kind of at the forefront in psychiatry, and you know, I think a lot of psychiatry organizations or psychiatry, as you know, PAs aren't really utilizing it. I think some places are kind of hesitant to bring in PAs or nurse practitioners, or or these other providers that can kind of provide that gap in care. But when you look at kind of the other side of seeing someone who's not a psychiatrist or waiting 2 months to see a psychiatrist, what is the better option there? And I think, telehealth was already a thing that was kind of expanding in psychiatry to provide care for definitely underserved or more rural populations. And I think now that COVID has really pushed telehealth forward, I think that's going to make a big difference to care, because I think that'll kind of expand the ability that we have to do telehealth. I think there's a lot of sort of restrictions with insurance companies and when you can or can't do telehealth, but I think telehealth will continue to expand, and hopefully I know in terms of psychiatrists and like psychiatry residencies, those are not getting any bigger. Those are probably shrinking. So I think really the way that's going to come to kind of help bridge that is relying on advanced practice providers like nurse practitioners and physician assistants to help fill that gap, because I don't really know how else they can do it when there's just not enough psychiatrists to do it.
Yeah, we totally agree, and we hope so, because as you know better than I'm sure anybody, mental health is definitely a real issue, and utilizing PAs and NPs and APPs in general to kind of fill that void is definitely something to consider for the future and for the better of people. But yeah, thank you so much for everything. That was an amazing session. This was one of our most
great.
Yeah, this was one of our biggest sessions ever.
Yes.
So we were like 230 viewers the whole way through. You didn't put anybody to sleep. Everybody's standing here.
Nice.
Yeah, absolutely. Yeah, thank you for everything, taking the time to do this, sharing your personal story, your battle with cancer. I know that's something close to you, and maybe you don't want to disclose it with everybody, but just the fact that you're willing to do that helps students back. We really appreciate it. So thank you so much.
Glad to help, and feel free to follow me on Instagram. Ask me any questions you have.
Yeah, definitely. We'll put that Instagram up one more time. We do encourage you guys to definitely follow. If your question was answered, or you have something else that you want to ask, not in public like that, definitely go out and do that. But yeah, you were great. You answered some really, really tough questions. They really wanted to put you on the spot, but you did awesome.
Good, thank you.
Yeah. Do you have any closing words for us or anything you want to say?
Not really. Glad to have been here to share, and thanks for having me.
Yeah, absolutely. Our pleasure. Definitely. Well, have a great night, and thank you again for doing this. And just one more thing in closing, I know you might go back to the YouTube video and kind of look over the chat, because it's kind of hard to do both at the same time, but we had so much support, like millions of thank yous. Everybody really was able to relate with you. This is our first time having a psych PA on, so people were so interested in this, and you did a great job. Like, everybody really loved you. So thank you.
Thank you.
Yeah, well, have a great night. Thank you again.
Thank you so much.
All right, awesome, everybody. Thank you very much for joining us. That was an awesome session. We learned a lot. We hope you did as well. We're gonna go ahead and post the quiz link now, and it's the same as usual, just 5 questions, nothing tricky. We just make sure that you were here attending. Yeah, you just need to make 4 out of 5 right, and we'll email you a certificate within the week. We did adjust the time on that since it was about 2 hours, so we're going to make sure you get credit for those 2 hours on your certificate.
Yeah, we do that for every session. So if it's an hour and a half, we'll make sure it's an hour and a half at the bottom. If it's 2 hours, 2 hours. If it's 1 hour, 1 hour.
Right.
But yeah, I did send out the link in the chat. So you have 1 hour to take the quiz, and you have to get 4 out of 5 correct to get the certificate. You have until 10:10 p.m. Central Time. So yeah, I think that's everything. Oh, I know it's kind of getting close to finals week, or is already finals week for some people. So good luck to everyone if you're taking a final.
Yes, absolutely. Good luck, everybody. And our next session is coming up on the 16th. Definitely stay posted for that, guys, because this PA is so into this. Like, he actually did like a mock session and went through the whole thing. It's awesome. It's going to be a little bit of a different format. He wants to focus on tips to help y'all actually get into PA school, and he wants to make it a more interactive experience. So if you have personal questions about yourself, he'll try and answer them on the spot. So that'll be really good. We're not going to have any other sessions that week because we really want to focus on that one. So we're looking forward to that. Stay posted on Instagram. We will let you know. But like I said, it'll be on the 16th. Yeah, guys, I think that is everything. Thank you so much again for joining us. We really appreciate it. Hope you guys had a great time. We'll be right here in the chat. If you have any questions about the quiz or anything in general, just let us know. All right, guys, we'll see you next time. Take care.